Please welcome up now for sexual dysfunction and fertility, Dr. Patel.
All right, thank you so much for that kind introduction, and thank you for having me come and speak about this very important topic. Once again, if there's questions, it's meant to be interactive. Raise your hand, stop me at any point. We've built in some time to include some questions at the end, but once again, feel free to stop me. Fertility is one of the main concerns amongst testicular cancer survivors. And over the last probably 2 decades, there's been a lot of focus on fertility preservation, which we're certainly getting better at. But more recently, there's been a focus on what's called oncofertility, or the discussion or concerns regarding fertility both before as well as after cancer treatment. It's generally well accepted that testicular cancer and its treatments can negatively affect fertility, and the goal really today is to kind of focus on what we can do to really optimize fertility in testicular cancer survivors. Naturally, it's important really to just kind of take a step back and kind of understand how testicular cancer and its treatments can impact reproductive function. And conventionally, it's been thought of that it's kind of a direct impairment in terms of sperm production, and that's largely related to like chemotherapy or radiation. But there's other factors that can also play a role, such as changes in hormones, like Dr. Shea kind of alluded to in his presentation before, sexual dysfunction like erectile dysfunction, changes in ejaculation, as well as other psychosocial stressors that could affect reproductive health. In terms of impaired sperm production, the sperm cells, they divide very rapidly. Most men are surprised to find out that they make 2,000 sperm a second. As a result, cancer cells are also rapidly dividing, and any sort of cancer treatment, chemotherapy, radiation that's designed to target cancer cells can also target these sperm cells. Thankfully, it's really dependent on, at least in terms of chemotherapy and radiation, the type, the amount, the duration that you've been exposed to it, and fortunately, usually the changes in production are temporary, although sometimes it can be more or less permanent. Even in men that are undergoing orchiectomy, the thought is that the discussion regarding fertility preservation should occur even prior to orchiectomy, because there have been studies that have suggested that in men with testicular cancer, or go on to get diagnosed with testicular cancer and considering an orchiectomy, about 25% of those men will have reduced semen parameters even prior to any sort of cancer treatment. Specifically those men with seminoma, and if they have a larger mass on the affected testicle greater than 4 centimeters, they're at almost a 2-fold higher chance of having abnormal semen parameters. So once again, important to kind of have that discussion kind of early on in terms of fertility preservation. About these other issues, so we kind of talked about the impacts in terms of testosterone, which is the male reproductive hormone, and kind of the whole axis that controls testosterone production. This is largely related to same thing, direct kind of impact on the Leydig cells, or those cells within kind of the healthy testicle that makes testosterone. Sexual dysfunction, so the erectile tissue is androgen sensitive, so in men that have low testosterone, they could be affected by how well or the quality of their erections. For men that have undergone RPLND, they could be affected by changes in ejaculation that could also affect their reproductive health. And then lastly, the psychosocial stressors. So not only regarding their cancer diagnosis, treatment, if they're able to kind of work and kind of cover bills, but then also this financial toxicity that might be associated with fertility preservation and anything that may come after that if they do need assistance in conceiving after they're kind of in remission or on surveillance for their cancer. Any discussion regarding oncofertility, really the foundation should be fertility preservation. And for men, that's basically just an ejaculated sample that basically gets frozen away. This has been supported by a lot of the major cancer organizations like ASCO for the last 20 years, and certainly we've been getting better about counseling, but the rates of cryopreservation are still fairly low. And cryopreservation certainly is very cost effective, and it's generally very reliable in terms of potentially conceiving using that sample if necessary in the future. In terms of those barriers in terms of the fertility preservation, I mean there's quite a bit of kind of inequities there. In terms of the counseling itself, like I mentioned, we're doing a better job, but it certainly could be even better than that. Men that are older typically don't get counseled regarding fertility prior to any sort of gonadotoxic therapy. Men from lower socioeconomic status or lower income, less likely to be counseled. Even in the men that do receive appropriate counseling, not all of them end up banking, and it's due to a variety of reasons. Cost is a big thing. Indecision regarding future fertility. I mean, if you ask an 18-year-old, hey, do you want kids in the future, at a time when they're kind of dealing with a lot of different things related to the cancer, and they may not know. They kind of have a timeline in terms of when it would make sense to be able to kind of preserve their sample before moving on to some sort of therapy. Of the men that actually get appropriate counseling regarding fertility preservation, only about 24 to 30% actually preserve sperm. Same thing in the percentage that actually get counseling, the folks that actually use that sperm is only 6 to 18%, so not that many. And that may mean that maybe they don't need it, or the cost related to utilizing that sample may be too much, and that may be another burden for them in terms of conceiving. In those men that do preserve sperm, the outcomes are very good in terms of paternity. So with the assistance of assisted reproductive technologies, I mean, the paternity rates are almost close to population at 50 to 80%. So certainly, if there is sperm frozen away, it can be very helpful if there is difficulty conceiving afterwards. A very common question that we get is that, hey, I have sperm stored away prior to my cancer treatment. We've been trying for a while, still hasn't been successful. What options do I have if I wanted to utilize that sample that I have stored away? When someone provides a sample for cryopreservation, basically it gets processed. Usually they'll give you an idea in terms of what the counts are. Then the sample will get kind of separated into a bunch of small little vials. It's placed in liquid nitrogen and it's frozen at negative 320 degrees Fahrenheit. Those samples are basically frozen in time, so the sperm no longer will age. When the time comes that the sample wants to be utilized, it basically will be thawed. That sample needs to be used with some form of assisted reproductive technology. So IUI, or intrauterine insemination on the left here. That's a simpler method where basically that sample is just taken, it's thawed, it's washed, and then it's delivered through a small little catheter into the partner's uterus. For that, you do need pretty reasonable sperm counts to be able to do that. The other alternative would be something like in vitro fertilization, or IVF, on the right. The main thing there to kind of realize is that it's definitely much more involved, much more costly. Success rates are certainly higher, but it really depends on kind of the situation that the couple is in. Here, this would require like an egg retrieval on the female side, basically merging the sperm and the egg together in the lab and then transferring that embryo into the partner's uterus. So logistically and cost-wise, a lot of burden that's there. Lastly, I want to kind of touch on kind of two unique patient scenarios that we sometimes will see in testicular cancer survivors in our reproductive urology clinic. The first one is post-chemotherapy azoospermia, or lack of sperm in the ejaculate after chemotherapy. And the second thing is changes in ejaculation. When we kind of think about post-chemotherapy azoospermia, that's probably one of the more challenging conditions that we have to deal with in kind of our field. And this is basically the lack of any sperm in the ejaculate. Depending on the type of chemotherapy duration that's given and the amount that's been given, it's variable in terms of whether the changes are temporary or more or less permanent. Historically, especially in younger children that we see, with specific alkylating agents, I mean, the risk of persistent azoospermia, even beyond 5 years, is almost up to 25%, so it's pretty significant. And that may be a consideration, especially for testicular cancer survivors, if they're getting other salvage chemotherapy or other therapies beyond what the original chemo was. If the patient basically has not preserved any sperm beforehand, or they used up the sample that they had stored away before their therapy, and now they have no sperm in the ejaculate, the gold standard in terms of treatment would be microtesticular sperm extraction, where basically a microsurgical procedure where we can open up the testicle, remaining testicle like a book, and then we can kind of meticulously go through the testicle and look for even a single sperm that we could use for IVF. The success rates are about 50%, but this does offer hope for those that are still wishing to have biological children where there really isn't no other avenue to do so. The second thing is changes in ejaculation. This is more applicable to men that have undergone non-nurse-bearing RPLND or a post-chemotherapy RPLND. And we kind of approach this more or less stepwise because there could be an issue with what's called retrograde ejaculation, where you're able to deposit the sample within the urethra or the urinary tube, but then it's kind of going backwards in the bladder, or anejaculation or failure of emission, where that whole process of it being deposited in the urethra is just not happening. Usually just based on the patient history, and then we will get a microscopic urine test after they've ejaculated. If there's sperm in the urine, that confirms that things are going backwards. In a lot of those situations, medical therapy can reverse it, probably up to 70% of the time, where 70% of those men that were going backwards can start shooting forwards. And that would make it so that you'd be able to potentially conceive naturally. If that doesn't work, then we can obtain or isolate the sperm through the urine, and if necessary, we can also surgically go get the sperm from the remaining testicle. With failure of emission or anejaculation, there's really not a role for medical therapy. Sometimes like vibratory stimulation or electrical stimulation can help cause orgasm or ejaculation. We can get the sample that way. Or if that doesn't work, same thing. Surgically, we can either with a needle or with a small little open procedure get some testicular tissue that we can get sperm from. So I apologize for kind of a lot of information in a short amount of time, but I want to kind of hit on a lot of things and happy to take questions.